Hello and welcome back to the first clinical talk in the afternoon session. My name is Zemi Harrabi and I'm a radiation oncologist at Heidelberg Ion Beam Therapy Center. Unfortunately, I'm not able to give this talk live today, but during the further course we will still have plenty of opportunities to discuss open questions or any other issues. In today's talk, I will give you an insight into the rationale for particle therapy for skull-based tumors. When talking about skull-based tumors and the need for particle therapy, probably the first thing that comes to everyone's mind is chordoma and chondrosarcoma. That at least was also my first thought when I had a look at the title of this talk. But during the further course, there will be a specialized lecture just on chordoma and chondrosarcoma of the skull base. So unfortunately, we won't talk about chordoma and chondrosarcoma right now. I refer here to Tuesday's lecture given by Julia Riva. So what else is there at the skull base? You can depict on the image that the skull base is the section where we have the transition of the brain to the rest of the head, and it is actually a quite critical localization. We will see that during the further lecture how many critical organs at risk are adjacent to the structure called skull base. So what kind of other tumors could we talk about? Well, there are meningioma, there are schwannoma, especially vestibular schwannoma, there are craniopharyngioma, pituitary adenoma, maybe esthesioneuroblastoma, juvenile angiofibroma. So you see there are plenty of other indications for radiotherapy with regard to the skull base, but today I would like to focus on just one of those entities, and this would be the largest entity, which is meningioma. So when it comes to treating tumors at the skull base, we have to face a situation which I'd like to refer to as a oncological dilemma. Because on the one hand, we need a really high prescription dose to treat maybe radioresistant tumor, but on the other hand, we are in close vicinity to so many critical organs at risk whose tolerance dose might be way lower than the RT dose needed to achieve a local control. And both follow a very simple principle. There is a clear dose-response relationship between tumor control on one side and normal tissue control on the other side. The higher the radiation dose is, the higher the probability I have to eradicate all tumor cells, and by eradicating them, achieving a local control and ideally also improving the oncologic outcome in terms of overall survival. But on the other hand, the higher the dose is, also the higher the probability for side effects, and especially in critical proximity to the brainstem, to the optic system, to the pituitary system, to the auditory system, you name it. I have to protect the surrounding healthy tissue. We would like to perform treatment with organ preservation, and especially for tumors with a good prognosis, we would like to reduce the late side effects as much as possible. And in between those two dose-response relationships, we have our therapeutic window where we treat the patient and where he benefits most from our treatment. And the trick to be inside this critical therapeutic window is especially best achievable with particle therapy. You might ask why. I will show you that on the next slide. I know. Some of you will say, not again a depth dose profile. This is probably the nth permutation of a depth dose profile from photons and protons you might have seen. But still, I know it's a very basic principle, but it is an extremely important principle. So here we have the typical depth dose curve of photons. We know we have a buildup with secondary electrons. Once we reach the equilibrium, we have a continuous decrease of dose. Particles, however, they are famous, at least from a physical perspective, for their so-called inverse depth dose profile, meaning that we have a low dose in the entrance area, and at the end of the range they deposit basically all of their energy very, very focused to a specific point in the so-called Bragg peak. And the trick is that by modulating the velocity and the energy given to the particle, we can modify the range in the patient. Of course, we all know that a tumor is rarely just at one spot, at one slice, so we always have to cover a 3D volume. And with active raster scanning or pencil beam scanning, what we basically do is that we put many of those Bragg peaks behind each other. Every Bragg peak, every slice has a different energy. We call that then spread out Bragg peak. And by putting many of those Bragg peaks behind each other, we have a peak area and a homogeneous dose distribution within the tumor. The big benefit and the big contrast to photons is that we have a lower dose in the entrance channel, because the particles are so fast, there's no time and almost no interaction with the healthy tissue. But maybe even more important is the distal part of the beam, where we basically have no dose distal to the tumor at all. Here in this graph, it's just visualize the dose distribution of a proton beam in water with a depth of roughly 16 centimeters. And quite similar to the graphic on the left side, we see that we have a low to intermediate dose deposition in the entrance channel. We see a somewhat pronounced lateral scattering in the depth, but here very focused at the distal end, a high dose, highly focused dose deposition. And what is extremely important, and what we use also in the clinic to treat tumors in very critical localization, is the steep dose fall-off. We see that we have a very steep gradient coming from 100% to 0% over a very short distance. Knowing the properties of a particle beam and the advantages compared to conventional photon beams, and knowing the anatomy of the skull base, it is quite easy to understand the rationale to use particle beams to treat tumors of the skull base. Here on the left, I depicted a couple of CT scans with contours, again visualizing the close vicinity of critical organs risk. We have the brainstem, we have the optic system, we have the inner ear, we have the pituitary, we have critical neurovascular structures, or the hippocampi, all with the potential to impact the quality of life of the patients on a long term quite significantly. And how relevant it is to spare those critical structures show the analysis from a colleague who had a look at the long-term side effects after treating patients for skull base meningioma. And we see that a significant amount of money, patients not only have any side effect, but especially the frequency might be surprising. If you look at the top right, patients who have problems to make decisions, handing over work to colleagues, delaying work, feeling isolated, slower work pace, concentration problems. So a decline of both neurocognitive function, working speed, and quality of life affects those patients not only rarely or sometimes, but a significant proportion of the patients experience those problems often and always. And whenever we have a problem with such a high incidence, there is obviously the need to improve the treatment to reduce those long-term side effects. As I said, the analysis of the quality of life affecting side effects we just discussed comes from an analysis of a cohort with meningioma. That's why I would like to shed some light on the meningioma and give you a background on that. On the right side, we see the distribution and the composition of the incidence of brain tumors in adults in total, and we see that meningioma is the most frequent indication, accounting for roughly 1/3 of the patients, followed by glioblastoma, astrocytoma, and a few other entities. The risk to develop a meningioma is age-dependent. As we can see here, the age-specific incidence increases significantly with increasing age. The median age actually at first diagnosis is 65 years. And there are a couple of risk factors, amongst them especially status post-radiotherapy, and also worth mentioning neurofibromatosis, especially type 2. Those patients have a 75% lifetime risk to develop meningioma. When it comes to meningioma, it is not just one disease, it's just the name of a family of different tumor types with different histologic features and especially also quite distinct differently biological behavior. The most common subtype of meningioma when it comes to classic histopathologic classification are grade 1 meningioma. Those are regarded as benign tumors and are responsible for roughly 80 to 85% of all meningioma first diagnosis. When it comes to classification under the microscope, they have typical features like a low mitotic rate with less than 4 per 10 HPF, and especially absence of brain invasion. Grade 1 meningioma can be further divided into 9 subtypes. The outcome is rather favorable, with a 10-year overall survival of 80 to 90% and also a 10-year progression-free survival in the same range of 75 to 90%. Next would be grade 2 meningioma. They are also called atypical meningioma, and they account for 15 to 18% of all diagnoses. We see that they have a higher mitotic rate. We see 4 to 19 per HPF, or histologic features are observed brain invasions, or 3 of 5 histologies, which are spontaneous necrosis, sheeting, prominent nucleoli, high cellularity, and small cells. And we see there's a distinct change of prognosis. The 10-year overall survival drops to 50 to 80%, and the 10-year progression-free survival, mainly also affected by the postoperative surgical status, drops to 23 to 78%. Bringing us to the next and last type, which are grade 3 meningioma or malignant meningioma. Fortunately, those are quite rare conditions. They account only for 1 to 3%, and they have an extremely high mitotic rate and typically a papillary or rhabdoid specific histology. The 10-year overall survival is even worse. We have just 14 to 43%. But if you look at the 10-year progression-free survival, that is really a major clinical challenge with an urgent need to improve the outcome, because there is no 10-year progression-free survival at all. So, as I stated before, a rationale for particle therapy might be two-sided. Either you would like to improve the local control by increasing the dose, perform a dose escalation, or if your oncologic outcome is already quite favorable, then you might aim for a situation to reduce the side effects. When it comes to meningioma, WHO grade 1, and we look here on the left to the Kaplan-Meier curve, we clearly see that for grade 1 tumors, there is no role for improving local control. It's just a flat line, meaning we have 100% local control, excellent local control. So there is no room for improvement. Nevertheless, we use CyberKnife, particle therapy, or any other kind of radiotherapy. And whenever we have such a situation that we have an excellent oncologic outcome, then the second goal of particle therapy is important, reducing late sequelae, reducing late side effects. And highly conformal radiotherapy yields at better sparing of critical organs at risk. And if we keep in mind that there are dose-response relationships for many of those critical organs at risk, that will potentially also lead to less side effects. Here on the right, we see a typical dose comparison of a plan with protons on the left side and a plan with photons on the right side. And photons here on the right side. If we look at the dose distribution, well, it just starts here with 25 gray, so 50% isodose of the prescription assumed is probably 54 gray in this publication. We don't see the really low to intermediate dose. Otherwise, the difference between the proton plan here on the left and the VMAT on the right would be even more pronounced. So typically in axial plane, depending on the beam geometry, if we have a 2 or 3 beam lateral oblique approach, we will just have dose here in the entrance channel, but especially no dose to the contralateral side. As I said, depending on the strategy and then beam geometry. But here in the VMAT plane, assuming that it's just a usual arc and not something fancy, non-conformal, non-coplanar VMAT arc, we would have low dose basically not only in the contralateral adjacent part here in the tip of the right orbita or the eye or the very sensitive lenses, but also here on the contralateral side in the temporal lobe, the brainstem, and basically all over in the transversal slices in the temporal lobes, the posterior fossa, and the healthy brain tissue. Well, you might say the difference is not that pronounced. However, again, repeating, there are strict dose-response relationships also for critical organs at risk. Let's have a look at the pituitary. The pituitary is not visualized in that slide, but it's close by. And we know that every excessive gray mean dose increases the risk for further impairment of the hormonal status. So starting with a dose of roughly 20 gray, and whenever the mean dose gets higher, the probability for impairment is higher. And this is exactly the spot and the range of dose which we are talking of. So potentially we can reduce also the dose over there, but also the critical neurovascular structures, the hippocampi, for example. There's a publication showing the relation between fatigue and brainstem dose, and those are all dosimetric or metrics which can be improved using proton beam therapy. What I just said was true for meningioma grade 1. The story is quite different when we go to meningioma grade 2 or even grade 3. Higher grade meningioma are called atypical or malignant, and their biological behavior is way more aggressive compared to grade 1 meningioma. And here, dose escalation can have a positive impact on the local control. As an example, I just depicted two different publications from Boskos and McDonald's. Here on the left side, showing the cause-specific survival Kaplan-Meier curves for 24 patients undergoing radiotherapy for either grade 2 or grade 3 meningioma. In this cohort, it was actually a combined treatment with photons and protons, but still we see that a total dose of less than 60 gray did worse in overall survival compared to the patient that received a dose higher than 60 gray. And also in the other publication, looking at the local control rate for grade 2 meningioma, there is also a quite clear dose dependency. Again, those patients who received a dose exceeding 60 gray had a significantly better local control rate compared to patients receiving a lower dose. And this is exactly where we can use the physical advantages of particle therapy, spare the critical optical system. The tolerance dose is typically at 54 gray, roughly, the brainstem at 60 gray, and skull-based meningioma at the sphenoid point typically have contact to both, where particle therapy increased the coverage of the GTV and CTV, and by increasing the dose whilst respecting normal tissue tolerance, we can do better for the patients, both for local control and the side effects. I won't go too much into detail for this slide. I just wanted to show that review that was published a couple of years ago, proving both efficacy and low toxicity of particle radiotherapy for patients with grade 2 and grade 3 meningioma. It was a systematic review, including not only patients who received protons alone, but it's a mix of all particles, it's protons and photons. We've just seen the survival curve of this publication. There's a combination of photon and carbons, proton and carbons, or proton alone. And if we look at the local control and the overall survival rate, those are quite promising. And depending on the cohort and the mix of patients, we have local control rates in the range that I showed also on the histological classification of up to 70–80%, especially for grade 2 meningioma. These days, the impact of molecular diagnosis gets more and more important. Currently, there's still a distinct lack of combining molecular data with outcomes, so I'm very much looking forward to see those results, not only for particles, but for radiotherapy in general. But to summarize, protons or particles are both effective and cause less toxicity for patients with meningioma. Coming to meningioma grade 3, the story is completely different. The prognosis is still extremely poor. We are just about to start to understand the mechanisms and the biology of malignant meningioma, and then still looking for new approaches, new treatment regimens to tackle the problem. If you remember, grade 3 meningioma, they have basically no local control at all. The 10-year local progression-free survival was basically 0%. I just talked shortly about molecular classification, which had a huge impact in classifying not only brain tumors, but also other diseases, or identifying druggable targets to refine treatment regimens. And this is a publication, a high-ranked publication in Lancet from Felix Sam here at our Pathology Institute, who molecularly classified malignant and other meningioma. And probably the most valuable thing is that he also correlated those molecular classified categories here of benign grade 1, intermediate or malignant meningioma, also with clinical outcome. And as we can see here, especially for the malignant meningioma, the progression-free survival is really, really poor. Here on those two Kaplan-Meier survival curves for progression-free survival, we see the classic graduation, grade 1, 2, 3, depending on microscopic histology. We see a quite good distinction between the tumor classes and the outcomes. However, it seems that the molecular classification goes beyond and is even better tool to distinguish between those classes. The benign prognosis might be slightly better, but still comparable. But we can better distinguish between intermediate malignancy and high malignancy. And we see that based on the molecular classification, the outcome is even worse. And whenever we have such a poor outcome for local control, we have a strong urge to improve our treatment regimen, to find new treatment concepts to improve local control. And since this is a particle therapy course, obviously particle therapy, not only with protons, where dose escalation might be possible, but especially with carbon ions might be worth to investigate what impact we can have on the poor progression-free survival for grade 3 meningioma. When talking about the rationale for particle therapy with carbon ions, please allow me to go one step back and explain this very basic physical rationale of carbon ions. But I think still, even if it might be a repetition, it's very important to understand and to know those small but still significant differences between the particles. So carbon ions compared to protons are really heavy, just simply to the size, because protons, the core, it's just a simple proton, and a carbon ions consist of a couple of protons and neutrons, so the mass and the size is significantly larger. And this we can see also in a very simple experiment regarding the lateral scattering, that the small and light proton has a significant deflection and scattering in depth. Also here on the right side, if we look what that has an impact on the full width half maximum in depth, we see that our precise, highly focused proton beam is in fact in a certain depth not that small and precise anymore. But looking to carbon ions, I would say it's rather acceptable to still talk of a very, very focused spot. So here we're talking about a few millimeters, whereas with protons in larger depth, the full width half maximum can reach actually almost not only several millimeters, but the full spot size reaches almost one centimeters. And a very simple but nice experiment I like to show is here a radiographic film irradiated with protons, helium ions, and carbon ions, showing the insignia of our university. And with protons, you have a guess that there is some image. With helium, it gets slightly clearer, whereas with carbon ions, it's a crystal clear image, and you can easily read here Heidelberg and the insignia of our institute, the medical faculty. So carbon ions, in addition to the biological advantages, which I talk in a second about, also have physical advantages because they have less scattering and are even more focused. What I don't show here is that they also might have a disadvantage. I will come back to that at the end of the lecture, because due to the size of the particle, we have something which is called fragmentation and tail dose due to secondary particles, which might have a higher range than the initial particle. We always have something like called a tail dose. We slightly see it here. I think the colors are not quite right. So after the steep dose fall-off, we still have a dose cloud of roughly 10% for a few millimeters. But we all know that the physical advantages of particles, especially carbon ions, is just half of the trick. The maybe more important rationale is the biological rationale. And this is where we need to talk about the radiobiological effectiveness of carbon ions. Radiobiological effectiveness, or RBE, is a very simple principle. For a given dose, heavy ions are more effective than protons. And the RBE is calculated by dose of X-ray divided by the dose needed with ions to achieve the same endpoints. So we have an isoeffective X-ray dose. And we're talking about the fractional dose. And basically, this decision was made to refer to the dose of carbon ions and other ions in gray, RBE, because basically all our clinical experience relies and refers to the effectiveness of photons. So RBE is often determined, for example, in cell culture experiments, at 10% of cell survival, and the RBE is calculated easily, the dose needed for ions and the dose needed for photons to achieve the same endpoint of 10% survival. And for example, if I need 10 gray with photons and with high LET irradiation or carbon ions, it would be 2.85. Then the RBE at the level of 10% survival is easily calculated, 10 gray divided by 2.85, resulting in an RBE here of 3.5. Of course, this is a very complex biological model, and I believe this morning that Piero told you about the different biological models available to calculate the RBE and how complex it is, and that it depends on many different endpoints, not only the single dose, the endpoint you're looking at, but also the cell type, etc. So in clinical routine, still, as a rule of thumb, we roughly have an RBE of 3 to 4. Let me just quickly repeat where the RBE comes from and what the differences are between low linear energy transfer irradiation, such as protons and photons, and high linear energy transfer radiation, such as carbon ions or other ions. In this experiment, we see the ionization tracks of low LET irradiation. So we see ionization happening here and here very sparsely. And if we look at the activation in the nucleus, for example, by gamma H2X staining and the damage caused in the nucleus, it is dispersed all over the nucleus. And one of my colleagues from the physics, that he likes to compare it to a handful of sand you throw in the air, like this little girl on the image, which is nasty and can cause at least a certain amount of damage, but is actually not that effective. But when it comes to carbon ions, he regards them as bad boys, and we really see these densely ionization track densely packed along the path of the flight from the carbon ion. And looking at the damage caused in the nucleus, we have a completely different picture. Instead of this dispersion and diversion all of the nucleus, we have this very focused spots along the path of an ion, very concentrated damages, like here on the image, the boys who put a handful of sand, put a little bit of water in it, maybe a couple of rocks, and then form this really big balls of mud. And yeah, it's a very simple image to get an idea why carbon ions are more effective, because if we're looking at a DNA molecule and the size of the DNA molecule, and we lie it here along the path of low LET irradiation, and we lie it along the path of high LET irradiation, we can easily understand that with an increased RBE, with high LET irradiation, we have a massive increase of direct radiation damage, especially double strand breaks, which are way more complex to repair for the cell. So given the really convincing physical and biological rationale, one could expect that there are plenty of clinical trials investigating the role of particles in the treatment, especially of malignant meningioma. But if you look here on the systematic review from Wu and colleagues, you see that in this table only a very, very few prospective trials are listed investigating the role of either a carbon ion boost, or here a four-arm comparison of carbons, protons, photons, or the combination treatment of photon and protons, or here protons with a drug called avelumab. This is actually a little bit surprising, but on the other hand, it's also not that surprising, because you remember that malignant meningioma has a very, very low incidence. So in order to conduct a clinical trial and to enroll a decent number of patients will take quite a long time. And I can only report here from the results from Marcy, which are currently in preparation to be published. But it is already known that enrollment has been stopped due to toxicity events, showing that on one hand we need a dose escalation because the previous RT concepts are not effective enough, but on the other hand we have a very small therapeutic window, and if we increase the dose too much, we obviously leave the therapeutic window and increase also the toxicity significantly. So this is still an unmet need to find new treatment regimens to improve the radiotherapeutic outcome of treating patients with malignant meningioma. So if we go a step further and start thinking what else can be done for patients, not only with tumors of the skull base, but for particle therapy in general, we definitely also need to talk shortly about new ion types. In this graph, I tried to sort them out because many of them are available, and sometimes it's the question which is the right one, and you're spoiled for choice because you have so many different options. So I tried to sort it a little bit. Here on the left hand there's the biological effectiveness, and on the other side we have the accuracy and the dose conformality. If you want, so as a short history, where we're coming from, we used to treat with cobalt earliest, with high energy X-rays, introducing IMRT. Then we had conventional protons or passive beam techniques. There was a short excursion for neutrons as well, but due to exceeding toxicity, we left that way. We also introduced IMPT, are treating now with carbon ions, and with neon, silicon, argon. A couple of those ions were already investigated at the Lawrence Berkeley laboratories. But I think there are two candidates which are really interesting, because you can really concept completely new treatment regimens with those, which is oxygen and helium. Oxygen, maybe even more than carbon ion, has a higher biological effectiveness, a very high LET. So when it comes to topics like optimizing hypoxic tumors, overcoming radioresistance, performing multi-ion beam treatment or LET painting, then oxygen is definitely an interesting candidate. But currently in the focus, and the next big thing, at least for us in Heidelberg, will be the introduction of helium ions. Why helium ions? I mean, this graph quite nicely shows it, because you have protons on one side and carbon ions on the other side, and then in the middle, just in the sweet spot, you have helium, and helium ions basically combine the best characteristics of both ions. Let me just quickly explain you why I believe that helium ions might be a very valuable addition to the currently available ion species that are in clinical routine. In this clinical example, we have a patient with a typical skull-base meningioma here on the left side, and this plan is a helium ion plan, and we subtracted it from a proton beam plan, and this is the difference plot. So we used the same beam geometry, the same fractionation, and we see that basically in the target volume, as expected, there's no difference, but just adjacent to our PTV, we have areas of increased dose in the proton plan. So if you want, helium is not a revolution, but rather an evolution. It's something like protons 2.0. So we have the same advantages, we use the same fractionation, but still they are just slightly more focused, less lateral scattering, and you see what a tremendous impact this can have in this standard meningioma case. So we spare up to 10 gray to significant volumes around the target volume. And if we look at those spider diagrams to different organs at risk, for example, the hippocampi, the inner ear, the pituitary, the brainstem, we see that helium ion has for every of those organs at risk the potential to reduce not only the Dmax but also the Dmean. And putting that into NTCP models, we can see that coming from photons over protons, helium has quite a big potential to further reduce the risk for radiation-induced side effects. Of course, this was just one clinical example, but it's the famous tip of the iceberg. We did a tremendous amount of work preclinically, in vitro, in silico, with blank comparisons, etc., trying to identify patients benefiting most from helium ion beam therapy, and we are just about to start the clinical implementation and the clinical trials with helium. But it's a while ago that we actually treated also the first patient with a scanned helium beam. This was a female patient with a recurrent solitary fibrous tumor of the skull base, originating from the dura. So in 2015, the patient had surgery with residual disease and was treated here to the right part of the posterior fossa with 60 gray RBE carbon ions with 3 gray per fraction. Unfortunately, in summer 21, she suffered from a recurrence here in the prepontine cisterna. We see this massive dural contrast enhancement, and here we have the target volume with regard to the previous irradiation. Due to the unfavorable localization and the proximity to the caudal brain nerves, surgery was not an option, so we investigate the potential for re-irradiation. During treatment planning, we actually compared the potential not only of protons and carbon ions, but also the potential of helium ions using the same beam geometry, etc. And surprisingly, the best compromise between tumor coverage and sparing of the previously irradiated area was with helium ions, and especially due to the reasons we discussed before, because protons, they are so light, so we have a significant lateral scattering, so the dose to the brainstem and to the previously irradiated area of the posterior fossa was way too high. And also with carbon ions, where the lateral scattering is better, we had the problem of the tail dose due to the fragmentation. And helium ions, they have less lateral scattering, slightly increased biological effectiveness, but not an as pronounced fragmentation as carbon ions. And this is why we decided to go with helium ions. And here we see the baseline MRI of that patient with the GTV before radiotherapy with a volume of roughly 1 milliliter. 6 weeks later, we already saw a partial remission, very good response after 6 months. And in the 12-month post-RT control, fortunately, we could achieve a complete remission. But what is also very important, there were absolutely no signs for radiation-induced side effects. So this was a very, very, very promising start for a very interesting journey that we are just about to start. And with that, I would like to thank you. And I'm very much looking forward to interacting with you and to answering your questions and to discussing with you the different topics. Even if it's not today, I'm sure we will have plenty of opportunity during the further course. Thanks.